It's now a delight to welcome Nik Plevris to the stage from the Edinburgh Group. He's going to be talking to us about monitoring in IBD.
Thank you, Nick. Hello, everyone. So I think monitoring inflammatory bowel disease is one of the key aspects of our treatment. We spend a lot of time discussing what biologics we should be using first line or how we can predict disease course in our patients, but that might not actually matter because as long as we monitor our patients effectively, we can ensure that patients are becoming well, but more importantly, we can identify those who aren't responding, implement change to try and prevent future problems from occurring. So over the next few minutes, I'll be discussing to you the clinical tools we have available to us to monitor inflammatory bowel disease, some strategies that we can adopt in the clinic, and what the future of monitoring might look like. Now, it is well established that both Crohn's disease and ulcerative colitis are progressive conditions, and both these conditions confer a whole host of intrusive symptoms to our patients. These ultimately will result in significant impairment in psychosocial well-being and reduction in quality of life. Now, we know in order to try and halt this natural progression of the disease, we should be aiming for resolution of inflammation at a mucosal level. And more importantly now in the era of holistic remission, we should be addressing some of the patient well-being and ensuring quality of life is also improved. We have clear guidance set out now by the STRIDE-2 recommendations that give us time-dependent targets to aim for and that ultimately state that we should be aiming for endoscopic healing in addition to normalization of quality of life. Newer targets like transmural histological healing are also coming into play, although these aren't defined treatment targets yet. Now, within our clinic, we have a whole host of tools that we can use to monitor our patients. And as we can see in this slide, we have a whole host of scoring systems that we can use to standardize and objectively measure whether we are achieving our treatment goals. If we start off with symptoms, unsurprisingly, resolution of clinical symptoms is one of the most important outcomes for our patient population. We also have some data from looking at the secondary outcomes of REACT-1 that symptom-based strategies may be beneficial in terms of outcomes in Crohn's disease. In addition, monitoring symptoms in combination with inflammation also allows you to identify when the symptoms aren't attributed to inflammation of the disease. However, we all know that especially in Crohn's disease, there's poor correlation between symptoms and mucosal inflammation. We also know that symptom-based algorithms, when compared to those that are based on objective markers in inflammation, perform worse. Nevertheless, symptoms are key, and there's a big push to try and understand how they may impact our patients and look at symptoms from a patient's point of view. If we look at current guidance, there's a big push towards using patient-reported outcome measures, although these can be somewhat limited in terms of the ones that we have available to us. But there is suggestion that we adopt systems like the PRO2 in order to assess how the disease is affecting our patients. Now, if we're striving for that endpoint of endoscopic healing, clearly ileocolposcopy is key. Guidance suggests that in Crohn's disease, this might be performed every 6 to 9 months, and in ulcerative colitis, 3 to 6 months. And what they've also suggested is that we can adopt certain scoring systems to assess whether we're reaching those endpoints. Things like the SES-CD in Crohn's disease and the Mayo endoscopic scores in ulcerative colitis. However, these scoring systems have limitations, they're time-consuming and can be cumbersome to form in clinical practice. We also have to think about the limitations of endoscopy. Our patients, when we ask them, know that this is an important test, but when you ask them about acceptability, this is the least acceptable monitoring tool that they accept for use in day-to-day practice. Endoscopy itself is also costly. We are limited by capacity, especially during the COVID-19 pandemic. And also the procedure does carry risk and complications associated with it. And this needs to be a bit more pertinent as well because we are seeing an aging population and we're seeing this compounding prevalence in inflammatory bowel disease. So is it the best monitoring tool for monitoring IBD? And should we be doing it as often as recommended? And I think this is where biomarkers come into play. And by biomarkers, I'm talking about CRP and fecal calprotectin. These are the most well-studied biomarkers that we have in inflammatory bowel disease. We know for the CALM study, which compared a treatment arm that involved treatment escalation based on CRP of less than 5 and a fecal calprotectin of less than 250, that patients had higher rates of mucosal healing at 1 year when it was compared to a treatment strategy based on symptoms alone. There's some debate in terms of cutoffs that we should be aiming for with regards to fecal calprotectin. And generally speaking, a cutoff of 250 does appear reasonable. This is based on a number of studies that shown that this cutoff correlates well with active disease, inflammatory bowel disease. Some caveats to that, though. We need to be aware in situations like in small bowel Crohn's disease, where values may be a bit lower. And what I would say is it is important we try and calibrate the calprotectin for our patients by performing it at the same time as we do things like ileocolonoscopy to try and establish personalized targets for our patients. So we now have clear guidance that we should be aiming for normalization of both CRP and calprotectin to within normal range. And we're very keen in using calprotectin in Edinburgh. We've been very early adopters and we've been using it routinely since 2009 based on the same ELISA assay. To date, we've performed well in excess of 88,000 fecal calprotectin assays. And within our practice, we maybe perform this on sort of 2 to 3 monthly intervals in a proactive manner, so irrespective of patient symptoms. And there may be key points with that time frame when we're doing it. What we can see in the graphs on the right-hand side is that use of calprotectin is increasing year on year, and this is mirrored by reduction in ileocolonoscopy. We also took the chance to establish whether if we use this treatment target of calprotectin and we monitor it, does it improve our long-term outcomes? And using all the calprotectin data that we had gathered, we performed this study to try and answer the question about whether you normalized your calprotectin within the first year of diagnosis in Crohn's disease, did that confer a prognostic benefit? And what we can see from the main figure here is that patients who normalized their calprotectin, shown in blue, to less than 250 within the year had a significant lower risk of disease progression compared to those that did not normalize, shown in red. Now, we also have a whole host of imaging modalities that we can use. Predominantly in Crohn's disease, MRI is the imaging modality of choice due to the lack of radiation that's required. MRI can be useful in establishing complications associated with the disease and also correlates with active inflammation that we see in inflammatory bowel disease. There is this concept of transmural healing as well, and if this is to become a future treatment target, we will be seeing much more imaging performed in our day-to-day practice. Intestinal ultrasound has also gained traction because this offers a test that we can do at the bedside or in the clinic that can give us immediate information and that can allow us to determine whether patients are responding to treatment. Now, we've spoken about the sort of clinical and disease and the sort of specific inflammation-related parameters, but as we mentioned, importantly, we need to be thinking about holistic remissions. We need to be thinking about patient well-being and monitoring that throughout the patient's journey. There's some really harrowing statistics when you look at this, and one example of this is when you look at incidence of psychiatric morbidity in patients with inflammatory bowel disease. They have a significantly greater incidence when compared to the general population, and also when you look at things like suicide, a much higher rate of attempted and successful suicide, especially within the first year of diagnosis. And this is only just one part of this patient well-being. There are a whole other aspects to quality of life, to patient well-being, that include things like symptoms and burden of disease, extraintestinal manifestations, sex, and sleep. How we monitor them in clinical practice can be difficult, and there aren't a huge amount of clinical-friendly tools that we can use. However, recently more research has been done into this, and an example of a tool that can be applicable to our clinical practices is the IBD disc, which is shown here. And this gives a nice visual representation of 10 key quality of life measures that can be monitored to see if they improve with time. Now, how might treat to target look? How might a tight monitoring treat to target strategy look in our current day-to-day practice? Well, if we start at the diagnosis of inflammatory bowel disease, I think it's key that we perform this comprehensive baseline assessment. And as shown here, there are a whole host of things that we should be looking at. We then should be entering into proactive monitoring phase. And ideally every 2 to 3 months, thinking about performing an assessment of our patient-reported outcomes, but also the biomarkers CRP and calprotectin. If we achieve those treatment targets that we set out, we continue in this proactive monitoring phase. However, if targets are not achieved, then this is when we need to be thinking about optimizing our therapy or possibly changing our therapy. And once we do that, re-entering that proactive monitoring phase. The other thing to remember is that there may be times where your symptom targets are not being met, but you're achieving biomarker resolution. And this, I think, is a key point where we should be looking possibly for alternative causes of symptoms in our patients. If we continue achieving our target and get to about the 12-month mark, I think this is where we should be thinking about repeating this comprehensive baseline assessment to see whether we've had an improvement, to see whether we're meeting our treatment goals. Again, if targets are met, we should go back into our proactive monitoring phase. But if targets are not met, we need to change, make an optimization, think about alternative strategies, and re-enter into our continuous monitoring phase. But as you can see, that is an intensive strategy, and there are lots of limitations and challenges that we may face in our day-to-day practice. These include things like capacity to do this, cost pressures, certainly in the NHS. Are these targets attainable with the treatments that we have, and will we end up switching patients and putting them in a worse off situation? And also the really important question of, is this acceptable to our patient population? Are they willing to engage with these strategies? But I'm hopeful that in the future there are new developments that will allow us to overcome some of these problems and limitations. For example, we now have point-of-care testing. We can do things like calprotectin in the comfort of patients' home. We can check CRP. We can do therapeutic drug monitoring for anti-TNF therapies. There has been a huge push into virtual consultations, and telehealth and teleconsultations will be key in allowing remote monitoring to allow it to be easier for our patients to engage. The other big thing that I think is really exciting is the development of mobile-based applications and wearables. Now, it's something like over 80% of the population own a smartphone, and I think this is a really powerful tool that we have. Already there are applications like the Health Promise app that has been shown to improve quality of life and quality of care in patients with inflammatory bowel disease. I think really interestingly as well, we can use biometric data to allow us to monitor our patients. And there are lots of studies that have shown things like sleep or step count can be associated with disease activity and even risk of hospitalization in IBD. Biometric sensors also exist, and sensors exist that can pick up things like CRP and IL-1 levels in the sweat of patients. There's also this introduction of artificial intelligence, and I think this can be key when it comes to assessment of endoscopy and help us in decision making. We already have pilot studies that show that AI can automatically grade endoscopic activity in UC as well as expert reviewers. And as we maybe strive to deeper understanding of the disease and possibly aiming for sort of this molecular resolution of inflammatory bowel disease, then our treatment targets will likely evolve, and we'll probably see monitoring things like diet, the gut microbiome, as part of our monitoring strategies. Now, what might treat to target of the future look like? And this is just one example of what we might see in the next few years coming to our clinic. We may have patients diagnosed with IBD, and then they're entering into this monitoring phase that is done purely remotely using things like biosensors or mobile applications. And I think the key thing here that we should be aiming for is that this monitoring phase is passive. So the patients don't need to input a lot of data. So in the background, our phones, our biosensors are picking up all the information that they need. This could be then fed into machine learning algorithms that allow optimization of the parameters that are measured, and they will then learn with time as well what is pertinent to that patient. If these passive monitoring strategies are picking up that the patient might be entering something like a flare state, then they can alert the patient and allow us to implement things like point-of-care testing to allow us to confirm whether there are signs of active disease. And then patients can be guided towards their medical practitioners, be it in a virtual manner or guided to self-help management applications to allow to achieve better control. So in conclusion, I just want to mention that early and effective treatment, adopting a treat-to-target approach with optimum monitoring strategies is key. In the advent of technological advances and a better understanding of IBD, we will see a huge shift in the way we monitor our patients. And I think ultimately future monitoring strategies should empower our patients, be less invasive physically and mentally, be more cost effective, and minimize unnecessary patient attendance to hospital, and ultimately with the goal of improving patient outcomes. Thank you.